present this case of 11-year-old boy who came to us with complaints of deformity of left elbow, left little and ring finger. He had a history of fall and injury to left elbow 1.5 months back, where he went to a nearby hospital diagnosed as elbow dislocation, treated with closed reduction and above elbow slab. After 3 weeks, the slab was removed and the parents noticed elbow stiffness and little and ring finger deformity. He was put on physio for another 3 weeks. The elbow stiffness was improved. He got full range of movements, but he had forearm stiffness and persistence of the little and ring finger deformity. Then he came to us for further management. So on examination, his left forearm was fixed in around 30 degrees of supination. The left elbow range of movements was 0 to 140 degrees. The 3-point bony relationship was altered. Radial head was palpable anteriorly and medially. There is cubitus valgus deformity at the elbow. The valgus stress test was positive. There is clawing of left, fourth and fifth fingers were there. And there is wasting of hypothenar area. So this is the presenting X-ray to us.
Any thoughts?
It's a translocation.
Yeah. So this is almost 1.5 month old?
Yes, sir.
And with an ulnar nerve palsy?
Yes, sir.
Okay. Maureen, any thoughts? How would you manage this? How would you go about this? You have any, pre-reduction X-rays of the elbow dislocation?
No, sir.
So this will need open reduction, and it's in this 6 weeks old. It's really challenge to bring that radial head on this side, and I think Alric and Mandar published this case report, and you have to do some soft tissue repair also. There is an avulsion.
So there was a bony chip which of the radius.
Yeah, it's seen that bony chip is probably seen. Yeah.
The only thing is that in translocation, typically the person is in pronation. I think here you said it was, so even on the X-ray it looks like he is in pronation. You said it wasn't, I think it must be in pronation. It's usually locked in pronation. Yeah, so I think as Maulin said, it has to be open reduced. And probably no, it is like this.
So Mandar, any thoughts regarding?
Okay. So this will require an open reduction.
So any thoughts regarding why this has occurred? Is this a primary injury or is it iatrogenic?
It's difficult to say. In our case report, we had drawn a diagram that where it can be a iatrogenic injury. So this is there is a possibility that this can be an iatrogenic injury itself.
Yeah.
Dr. Mandar, what incision, what approach, surgical approach would you use?
So this will require probably a collateral approach on the medial as well as the lateral side. And again, it's not going to be a very easy surgery.
So I asked specifically regarding iatrogenic because it is known that in posterior elbow dislocations, pure posterior elbow dislocations, if during reduction the forearm is held in pronation, it does result in this. So it is something that I can secondarily. I mean, it starts off as a posterior dislocation, but it turns to a translocation. Sheetal, any thoughts on this? How you?
No, I think I'd like to see what was done, and
Okay.
so it's a translocation. It's a difficult thing. Sometimes acutely, if you get it, it can be close reduced because there is a lot of soft tissue injury. So it's all mobile because of the extensive soft tissue injury. But in someone who is presenting late, it needs to be open reduced. But
Okay, so can you go ahead with your management?
I think one thing which requires clarification.
So here the ulna is in place. That is one thing which is different. The olecranon is still articulating with the olecranon fossa. So probably it's just.
But not on the AP view.
Only the radius has shifted over to the other side.
Not an elbow translocation, it is a radial head translocation. That's the difference between their case and
Yeah, you're right. Because I couldn't see the AP of the. Okay.
put it other way around. That's why we.
So can you go ahead with your management?
So we did, we go through posterior approach and did open reduction of the radial head with annular ligament repair and neurolysis of the ulnar nerve. So this is the elbow range of movements which was full. And elbow he had a valgus stress test was positive, valgus instability was there. And this is the medial side where the radial head was lying medially, and this is the ulnar nerve which found adherent to the radial head. So this is the post-op X-ray, and these are the follow-up X-rays at 3 weeks and 6 weeks. So radial nerve transposition is very rare. It can be easily missed initially. The etiology could be iatrogenic or the initial injury in which there is a fall on outstretched hand. So the latter is found to be the most common cause than the iatrogenic cause. Radiologically, sometimes it may show, we may miss this easily. So it may show a normal articulating elbow, but there is a mediolateral transposition may be missed. The posterior dislocation with translocation can be treated by close reduction provided the injury is recognized and treated at the earliest. So the recognition of this injury needs extra vigilance. Good quality AP and lateral radiographs is essential before and after the reduction of elbow dislocation. So ulnar nerve is the most commonly involved. Early detection and prompt intervention can give good outcome.